Hello students, welcome to Medical Lecture Series. Today we are going to have a discussion of leukemias. My name is Dr. Machera. This is a lecture series dedicated to clinical science students. And don't forget to subscribe at the end of these lectures and put a notification on so that you can be updated with daily coming lectures. I used to update lectures daily, so it's better to have a notification on so that to be updated. Don't forget to subscribe. To have a beginning of our discussion, I would like to start with the introduction. Introduction, I would like to have a general concept of pathology or disorders of the white blood cell. When we are discussing leukemia fall under category of disorders of white blood cell. And these are disorders of white blood cell which we say they are grouped into two groups. We have disorder of white blood cell leading to decreased number of white blood cell. There is a low number of white blood cell. This is what we call leukemia. We also have disorders of the white blood cell leading to increased number of white blood cell. This is what we call leukocytosis. So to insist, when we say leukemia, we means decrease in number of white blood cell, and when we say leukocytosis, we mean increase in number of white blood cell. So we are coming into so we have our pathway which we are starting with. This was WBCs. We said they have pathology. Their pathology fall into two categories. We have leukopenia and we have leukocytosis. So in leukemia, we are going in leukocytosis direction. We are not going in leukopenia direction because leukemia are disorders of white blood cell which lead to increased number. That's why I'm saying we are going in the direction of leukocytosis and not leukopenia. So we say generally leukocytosis increased number is due to proliferation of white blood cell. So proliferation disorders of the white blood cell leading to leukocytosis, leading to increased number, they are further classified into two groups. We have those which are due to reaction against microorganism. We call them reactive proliferation. And we have those which are due to mutation of the cell. There is abnormal in cell division. The cells are highly dividing due to mutation. These are known as neoplastic. So I would also like to insist that we choose to go in leukocytosis pathway as far as leukemia is concerned. In leukocytosis pathway, we found that the disorders of white blood cell leading in leukocytosis, they can be divided further into two groups: reactive proliferating and the neoplastic proliferation. As far as leukemia is concerned, we are going in the neoplastic pathway. Leukemia is not due to reactive proliferation, it is due to neoplastic. As I said, reactive proliferation are due to increased number against infection, while neoplastic proliferation are due to uncontrolled cell division. Just to insist on reactive proliferation. In reactive proliferation, it is further divided into two types. We have, this is reactive proliferation. Reactive proliferation is divided into two types. We have simple one, this is simple leukocytosis, and we have leukomoid reaction. In simple leukocytosis, we say this is when there is just a significant small number of rise in WBCs. This is when, remember, we have the blood vessel, and within the blood vessel we have the blood. So when the blood contains WBCs are circulating in the blood in the blood vessel, fighting against microorganisms such as most of the WBCs which are mature, they will tend to stick on the endothelium of the blood vessel, and they will just leave a small number of WBCs which are circulating within the blood. But when there is an infection, when there is a bacteria infection, this number of these WBCs which was sticking on the endothelium, they will jump from the endothelium wall into the circulation. So by so doing, they will increase the number of WBC. They will increase the number of WBC. This increase in number is very small. So that's why we say this is a simple leukocytosis. It is simple because the number of WBCs are very small. But when there is so many microorganisms, in the blood, to the extent that both the WBCs which was found on the endothelium and those which were circulating in the blood are not enough to fight against this bacteria. So we have to stimulate the bone marrow. We have to stimulate the bone marrow to produce other WBCs, When these WBCs are produced, they will come into the circulation also. They will increase the number of WBC in the circulation. And these WBCs, most of them will be immature WBCs. So we have a high elevation of WBCs within the blood containing mature and immature cells due to stimulation of the bone marrow to increase WBC production. This is known as leukomoid reaction. In leukomoid reaction is when the bone marrow is stimulated to recruit more WBCs into the circulation. So that is to insist that the reactive proliferation is divided into simple leukocytosis and the leukomoid reaction. Okay, actually that's not a part that's not our direction. Our direction as far as leukemia is concerned is neoplastic. I'm spending much of time in introduction part so that this is a very important part to have a fundamental understanding so that we can proceed with our discussion in a simple way. So in neoplastic, we say the proliferative disorders of WBCs due to neoplastic, they can either be leukemia or lymphomas. So you can, I'm sure now you know that our pathway in this discussion was leukocytosis, not leukopenia. In leukocytosis, we said it was due to reactive proliferation and neoplasia. We said as far as the leukemia is concerned, we are going in neoplasia. In neoplasia, we said they can be leukemia. They can be leukemia or lymphomas. So now you understand it, that when you are discussing leukemia, we are in this direction. In next session, we'll have to discuss lymphomas. So for now, just concentrate on leukemias and the lymphomas. Sorry, leukemia only. Next time we shall discuss lymphomas. So leukemias are characterized by proliferation of abnormal white blood cells involving the blood. That is a very important point to note. Involving the blood and the bone marrow. Involving the blood and the bone marrow. It is quite different with lymphomas. We shall see lymphomas is elevated number of WBCs due to neoplastic involving lymphoid organs. So this is bone marrow and the blood as far as leukemia is concerned. So we are saying leukemia is neoplastic proliferation of WBCs involving blood and the bone marrow. These abnormal white blood cells accumulating, they interfere with the production of normal WBC. They interfere with the production of normal WBC as well as erythrocytes. These are RBCs and the platelet, resulting into anemia. When you have low number of WBCs, you are likely to have anemia. When you have a low number of platelets, we say thrombocytopenia. So elevation or abnormal proliferation of white blood cells, they interfere with the bone marrow so that the bone marrow cannot form normal WBCs, and they cannot form erythrocyte RBCs. Failure of bone marrow to form erythrocyte lead to anemia. That tells us that the patient with leukemia presents with anemia. Also, impaired platelet formation. Impaired platelet formation will lead to thrombocytopenia. That tells us patient with leukemia, they will present with bleeding disorders. Leukemia are classified into two ways. We use two criteria to classify leukemias. We can use the type of WBCs being affected. You remember, type WBCs are of different types. So we use the types of WBCs being affected to classify leukemia. That is criteria number one. In these criteria, we say if the granulocyte and the monocyte are affected, that is myelogenous leukemia. That is myelogenous leukemia. To insist, myelogenous leukemia, this is when the myeloid lineage of WBCs production is being affected. I'm sure you remember, when WBCs are produced in the bone marrow, they can go into two pathways. We have myeloid lineage, myeloid lineage, and we have lymphoid lineage, myeloid lineage and lymphoid lineage. So in leukemia, when there is pathology in myeloid lineage, they will cause a type of leukemia which is known as myelogenous leukemia. Okay, the second part, as far as this criteria is concerned, when it is lymphoid lineage which is affected, we have a type of leukemia which is known as lymphocytic leukemia. So to summarize, based on the type of WBC, leukemia can either be myeloid leukemia or lymphoid leukemias. Okay, the second category of classifying leukemia is based on cell maturity. Cell maturity means whether the cells are matured, or whether the cells are immature. Remember, when we are saying matured, we are talking of those cells which are affected, leading to abnormal proliferation. Also, when you are talking of immature, I mean that cells which are affected are immature. So to understand that, I would like to go back in the bone marrow and see how the WBCs are formed. So we have the WBCs formation in the bone marrow. WBCs formation in the bone marrow, they start from a single cell, which is the pluripotent hematopoietic precursor cell. The pluripotent hematopoietic precursor cell will differentiate and form pluripotent stem cell. Of course, this is a stem cell. You remember what is a stem cell? Stem cell is a cell which can retain its ability of cell division. So the pluripotent hematopoietic precursor cell will form pluripotent stem cell. These are two cells. They have formed from division from a single cell, and this stem cell will also divide and become two, and this one will divide and become two. This one will also divide and become two. This one divide. As they are dividing, they are decreasing in size and they are becoming mature. So in mutation, it depends where the mutation has occurred. For example, if the mutation occur at this point, meaning that, or at this point, we have immature WBC. The cell will be immature. When they will be immature, meaning that they cannot even function because they are still immature. They don't even know how to recognize microorganisms, so they are immature. Number two, since they are immature, they will proliferate in a very rapid fashion. Remember, as a cell is immature, the speed of proliferation increases as compared to mature cell. So in immature, WBC cells, the disease will present itself very early. Why? Because the WBCs are very native. They don't know anything about infection, and they are proliferating in a very high fashion. So the disease will present early in life. That is the acute leukemias. That is the acute leukemia. So to insist, when we have number of WBCs which are immature, will cause acute leukemias. And when the WBCs produce the mutation occurs in a very late stage, like here, in a very late stage, for example, here, we have a cells which are mutated, but these cells are at least matured. Because they are matured, they can a little bit function. They can recognize the microorganism and try to fight. And another issue is that when they are mature, the speed of proliferation will be very small. So even the disease progression will not be very rapid. It will be very slow. So we'll have late presentation of the disease, and that is a chronic leukemia. So to summarize, when you depending on the maturity of the cell, when we are saying acute leukemia, this is when mutation occur in early stage in blast cell. And when we say chronic leukemia, this is a mutation which occur in late stage and occur in matured cell. So we have to see how we say when we are talking of leukemias, we are talking of blast cell, highly mature. When we are talking of chronic leukemias, we are talking of matured cell. So, general evaluation of patient with leukemia, whether it is acute or chronic. Generally, how do we evaluate the patient with leukemia? Remember, we said leukemia, abnormal proliferation of white blood cells impair the normal proliferation of white blood cells. When there is abnormal proliferation of white blood cells in neoplastic, they will impair the bone marrow from producing normal WBCs. And you remember the function of normal WBCs is to fight against infection. Therefore, the patient will have risk of infection. So it is very important to evaluate evidence of infection, particularly bacteria infection. The second, we saw that when there is a high proliferation of WBCs, the bone marrow will be very busy, to produce WBCs and forgetting to produce platelets. And the platelets are responsible for blood clotting. So if the patient have low platelets and impaired blood clotting, this patient will have a risk of easily bleeding. So you have to evaluate evidence of bleeding. You have to evaluate evidence of bleeding and easy bruising. Another issue is sometimes leukemia, these highly proliferated cells, they can invade the lymphoid tissues and leading to lymphoid tissue enlargement. That we say lymphadenopathy. So you have to evaluate the evidence of enlarged lymph node. Also, we have reticuloendothelial cells, the liver and the spleen. They can be invaded with these cells, leading to hepatosplenomegaly. So you also have to evaluate the patient if the patient has evidence of lymphadenopathy or hepatosplenomegaly. Another issue, we saw that when there is leukemia, the bone marrow is affected from producing RBCs. It does not produce RBCs. So when the bone marrow does not produce RBC, we said it caused the patient to have anemia. That's why I'm saying in evaluating a patient with leukemia, you should also check for sign of anemia. Check the sign of anemia. And the last issue is fatigue and white loss. Remember, highly proliferating cells, for the cell to proliferate, it needs energy in form of ATP. So there will be highly consuming of energy storage within the body. And since the energy stored in the body, particularly when the glucose is highly consumed, we have to use alternative source of energy, which is fat. So the body, the cell will utilize the fat to produce energy, and this will lead to weight loss. Again, fatigue can be explained also by anemia. Okay, we are starting now to discuss acute leukemias. Remember, I said we can classify leukemias based on cell type and based on cell maturation. In cell maturation, we said when the mutation is in a very early stage, we have acute, and when it is in a late stage, we have chronic. So generally, we say acute leukemias account for 60% of all leukemias. So you can see only 40% remain for chronic, while 60% is for acute leukemias. And based on the cell type, 20% of leukemias are in lymphocyte, while 15% are myelogenous based on the cell type. So we say 25% are chronic lymphocytic leukemia. Remember, when we say chronic, meaning the cells are mature, we say lymphocytic, not lymphoblastic. When we say acute, the cells are immature, we say lymphoblastic, not lymphocytic. For testing purposes, the age of the patient can be a simple yet important aid to confirm the correct leukemia diagnosis. This is epidemiology and just tell us that show that patients less than 15 years of age are most likely to have acute lymphoblastic leukemias. Remember again, acute are cells which are immature. So if they are mature, they are blast, not cytic. It is acute lymphoblastic leukemias. While those greater than 60 years of age, they are typically to have chronic. If it is chronic, it will be lymphocytic, not lymphoblastic. Again, leukemias. Also, to insist, acute myeloblastic and chronic myelocytic leukemia, they both present at the age of 40 up to 60. General characteristic. Okay, we say we have two types of leukemia. So I'm combining the two criteria used. So we have acute, this is cell maturation, myelogenous, this is cell type. Again, it's leukemia which we are discussing. This is a neoplasia of myelogenous progenitor cell. Acute myelogenous leukemia occur in adulthood, as I said in the previous slide, that both acute myeloblastic and chronic myelocytic, they occur in 40 to 60 years of age. That's why I say it accounts for 80% of adult leukemias. Risk factor for leukemias, meaning risk factor for abnormal proliferation or neoplastic proliferation of white blood cells. This is a general risk factor as in other tumors. I mean, in other neoplastic condition, we have exposure to radiation. Of course, we have myeloproliferative syndrome. Again, Down syndrome can also be the risk factor. Prior chemotherapy, of course, this is anti-cancer drug like alkylating agents. We have the response to therapy is not favorable as in acute lymphoblastic leukemias. Also, we have poor prognostic indicators. The poor prognostic indicators which indicate the prognosis of the patient are old age. When you are in the old age, meaning you have a poor prognosis. Presence of other comorbidities, for example, you have leukemia, you are also hypertensive, you are also diabetic, so that is a poor indicator of prognosis. Again, history of exposure to cytotoxic agents, it is also a risk factor. Okay, the last is the radiation therapy. It is also a risk factor and a poor prognostic indicator for leukemia. So coming to acute lymphoblastic, we are discussing acute myeloblastic. In acute lymphoblastic, we say neoplasia, these are of early neoplastic progenitor cell which reveal predominance of lymphocyte, We say all acute lymphoblastic leukemia is the most common cause of malignancy in children with the age of 15 years of age in the United States. It is leukemia. This is the leukemia, acute lymphoblastic leukemia. This is the leukemia which is most responsive to what? To therapy. Don't forget, acute lymphoblastic leukemia is very common at this age and very responsive to chemotherapy. So that's the point you should note. Okay, in acute lymphoblastic leukemia, prognostic indicator include patient with age less than 2 years and above 9, with WBC above 105 per milliliter mercury, and the CNS metastasis. That is a poor prognostic indicator. The also presence of any of the following is associated with increased risk for CNS involvement. So when you have B type and increased LDH, rapid leukemic cell proliferation, of course, these are indicators of having CNS involvement. Okay, note that many patients with acute leukemias can be cured completely. Remember, I said acute leukemias, they can respond well to chemotherapy. Why? When you are giving anti-cancer drug, some of these anti-cancer drug, they mimic raw material used for DNA synthesis, for example, nucleotide bases. So when we are feeding these cells with fake nucleotide bases, it is those cells which are highly immature will be the one to pick up those drugs in a high rate as compared to mature. That's why acute respond well to medication as compared to chronic. But to insist and remind you, if they are untreated, they are most aggressive, and within few months you can lose the patient. The patient can die. You can lose the patient. Why? Because they proliferate very rapidly, and then they lead to high progression of the disease and leading to fetal outcome. So how does the patient with the acute leukemia present? The patient with acute leukemia, as they said, they present with anemia as a complication of not producing RBCs which are enough. So by so saying, you should evaluate for signs and symptoms of anemia, such as difficulty in breathing and paleness. So the second clinical features to evaluate is increased risk for infection. We said when you have abnormal proliferation of the WBC, they will cause the bone marrow not to produce normal RBCs. By so doing, the bone marrow will produce less normal RBCs and many abnormal RBCs, causing the patient to have impaired immunity and being at risk of increased bacterial infection. So you have to remember that. Okay, in this patient, you have to evaluate for sign of pneumonia, sign of urinary tract infection, to check for cellulitis and pharyngitis without forgetting esophagitis. Okay, another issue associated with high mortality and morbidity and life-threatening are these infections. That's why we have to evaluate them and manage them accordingly. Another clinical features which you have to evaluate in a patient with leukemias is thrombocytopenia, risk of bleeding. As I said, abnormal proliferating WBCs, they impair platelets. When they impair platelets, they put a patient at risk of easy bleeding. So you have to evaluate sign of easy bleeding, such as nose bleeding, which is epistaxis, bleeding in the puncture site. For example, you're cannulating or giving intravenous drug. Once you remove the syringe, the needle, the patient, the injecting site keep bleeding. So petechial and the ecchymosis, also you have to evaluate them because these are sign of clotting disorders. You have also to check splenomegaly together with hepatomegaly and the lymphadenopathy. I said these abnormal proliferating WBCs in leukemia, they can invade reticular endothelial system, which is the spleen and the liver, as together with the lymph node. And once they are infected, once they metastasized to those areas, they will lead to enlargement. Also, we have to check for bone and the joint pain. Of course, the bone and the joint pain is due to invasion of the periosteum of the bone. Of also diffuse or focal neurological dysfunction when there is involvement to CNS. That is to check whether they have meningitis and seizures. So it is very important also to evaluate on that. We have also to check testicular involvement. Testicular involvement is common in acute lymphoblastic leukemia. Again, I said acute lymphoblastic leukemia is common in patient with 15 years of age. So you have to check for testicular involvement, that is testicular enlargement in patient with leukemia. Also, anterior mediastinal mass. That is the involvement of the anterior mediastinum. This is mostly common in T-cell acute lymphoblastic leukemias. Acute, you remember, lymphocyte, we have T and B. When we have T lymphoblastic leukemias, they can lead to mediastinal involvement. The last is skin nodules, particularly in acute myeloblastic leukemias. That is skin involvement of leukemias which are acute myeloblastic leukemia. Diagnosis, how to make a diagnosis? Of course, the patient can have leukopenia or leukocytosis depending on the stage. In very late stage, they have low number of WBCs which are matured because the bone marrow has been impaired from producing the normal WBCs, and as the bone marrow is being involved, it will lead to impaired bone marrow production of WBCs. So that's why I say they can also present with leukopenia, but in most cases we expect leukocytosis. Okay, sign of anemia, thrombocytopenia, as I said, and the electrolyte imbalance. Electrolyte imbalance, for example, hyperuricemia. Hyperuricemia meaning that when we are having high number of WBCs being formed, and once they are formed, they will die. When they are dying, they will secrete uric acid, which is a metabolite found after metabolism of nucleic acid, that is DNA and RNA. So we have hyperuricemia, high level of uric acid in the blood. That's why we have to check hyperuricemia. Check hyperkalemia and also hyperphosphatemia. When we have high cell, you remember we have calcium, which is high intracellularly. When the cells are dying, so they will release high level of calcium within the blood and leading to hyperkalemia. Hyperkalemia will be one of the electrolyte imbalance. We have also hyperphosphatemia. Of course, the hyperphosphatemia is from bone marrow demineralization, which leading to increased high level of phosphate. Okay, another issue during diagnosis, you can do a bone marrow biopsy. This is required for making a diagnosis, particularly in acute lymphoblastic leukemia, which it will reveal blast cell blast cell of lymphoid in origin in greater than 20% of the patient. In acute myelogenous leukemia, it will reveal proliferation of blast of myelogenous lineage and an aura rods, especially if it is in the APL phenotype. Aura rods, these are granules and eosinophilic load inside the malignant cell and are present in acute myelogenous leukemia, and they are not present in acute lymphoid leukemias. So the presence of aura rods, they are only present in acute myeloblastic leukemias and not lymphocytic leukemias. Treatment of complication, for example, if there is infection, you have to treat. If there is anemia, you have to treat. If there is bleeding disorders, you have to check for platelet and give platelet transfusion. So you will have to give antibiotic to control infection. You have to give blood transfusion to control anemia, and also you have to give platelet transfusion to control bleeding. So that's how you have to manage as far as the complication is concerned. The second modality of management is to manage the problem itself, to manage the tumor itself. So in this category, we have combination chemotherapy. Combination chemotherapy in high dose. This is given for several weeks and is appropriate to obtain remission, that is absence of leukemic cell in the bone marrow. This is aggressive combination chemotherapy at a very high dose in several weeks, which lead to appropriate remission, that is absence of leukemic cell in the bone marrow. After that, you will have to, once remission has occurred, we'll have to go for maintenance therapy. Maintenance therapy is used for months and years. That is maintenance therapy. Okay, in acute lymphoblastic leukemias, we say more than 75% of the children with acute lymphoblastic leukemias achieve complete remission. Remember, I said acute lymphoblastic leukemias and acute myelogenous leukemias are very responsive to chemotherapy. That's why we say they will have complete remission. Relapse, when they occur, they are also usually responsive to treatment. When there is recurrence, they can respond well to treatment. We say with aggressive therapy, survival rate in children up to 15 years of age or longer is up to 50%. And almost 50% of the patients are also being cured. In acute myeloblastic leukemia, this is more difficult to treat, and those does not respond as well as does not respond to chemotherapy properly. Survival rate are considerable lower despite intensive treatment. Bone marrow transplantation will give a hope in this patient. Okay, we have finished the acute leukemias. Let us now have a look on chronic leukemias. So the general characteristic of chronic leukemias, as I said, chronic leukemias involve matured cell. That's why they are chronic. We say they are lymphocytic and lymphoblastic. This is the most common leukemia in Western world, and the most common leukemia that occur at the age after 50 years. Most patients with chronic lymphocytic leukemias are above 60 years of age. They are caused by monoclonal proliferation of lymphocytes that are morphologically mature but functionally defective. They do not differentiate into antibody forming plasma cell. In general, this is the less aggressive type of leukemia. Why I said chronic? Because they have matured cell. So the matured cell, they can at least function. So chronic leukemias have matured cell which can at least function. That's why the patient, we say this is least aggressive, is less aggressive, and the survival rate, survival time is long as compared to acute one. The natural history of the disease varies, but may follow a prolonged indolence cause many patients die of other condition. Clinical features, of course, clinical features are the same as patient with chronic leukemias. There is usually, but they are the same, but usually asymptomatic at the time of diagnosis. So we have painless lymph node involvement, that is lymphadenopathy. We have hepatosplenomegaly, as I said. We have risk of infection. There is also evidence of anemia and easy bleeding. Diagnosis again is the same as the acute leukemias. You have to check number of WBC, you have to check anemia, you have to check thrombocytopenia and then neutropenia. So it is the same as acute leukemias. Coming to treatment, of course, we say treatment, patient with asymptomatic disease are typically observed, but regime for patient with symptomatic chronic lymphocytic leukemia, it varies with the ages. Young patients do receive combinational chemotherapy. Prognosis is variable depending on the number of lymphoid tissue and the and the presence or absence of complications such as anemia and thrombocytopenia. Peripheral blood smear, of course, is very important to make a diagnosis. It will reveal absolute lymphocytosis and reveal smudged cell, that is a fragile leukemic cell that can rupture when placed on the glass. Flow cytometry reveal clonal population of B cell, and the bone marrow biopsy will reveal infiltration of leukemic cell in the bone marrow. So that is it for lab investigation in part of peripheral blood smear. So that marks the end of our discussion of leukemias. In next session, we'll have discussion of lymphomas. So keep watching for update for the upcoming discussion of lymphomas. Thank you very much.